A very good evening and warm welcome to all of you again for yet another masterclass from Scale series. This is the series in embryology. We also do a masterclass series in advanced ART as well. So today we have a well-known teacher, speaker, and a mentor for many of us in the field of embryology. He's none other than Dr. Gaurav Majumdar, who is the lab director at Sir Ganga Hospital. And we are going to discuss and learn a lot from him. And we prefer that it is an interactive session. It's going to be deep dive into IVF and ICSI from lab to life. We have the next slide. Yes, just to have a glimpses of our previous master classes. First class we did on all about fertilization. Then we moved on to implantation, and then we had about oocytes, which was done by Dr. Rajvi Mehta. And then today we are going to have about IVF and ICSI. And then we had our first episode of advances in ART by Dr. Sanjeev Reddy, who did about advances in diagnosis and management of RIF. So our next masterclass on advanced ART will be scheduled on 17th of April. This is going to be on endocrinology in stimulated cycles. This is going to be dealt with Dr. Sachin Kulkarni, who is a well-known teacher and is the authority in teaching us endocrinology in ART. And also our next embryology masterclass will be on 8th of May, which will be on embryo quality assessment, techniques, variations, and beyond. With this, I would like to invite Dr. Gaurav Majumdar, who is the lab director, clinical embryologist at Ganga Hospital, and he has over 20 years of working experience. He's a vice president of Academy of Clinical Embryologists, past chairman of Embryology IFS. He's a convener SIG, KPI and audit, and IFS 2024-26. And his interests are data management, KPIs, and quality control in IVF. So, and also he's been, training a lot of fellowship candidates and students in the field of embryology. We wholeheartedly thank you for accepting to, address this gathering today, and we welcome you to take over for the further masterclass event. Thank you so much.
Right. Thank you very much, Dr. Vasundara, for giving me an opportunity to be part of such an exciting series of masterclasses, these scale masterclasses. So I'd like to congratulate you for having these and generating so much interest in clinicians and embryologists. And I'd probably just share my slides and get on with it. And thank you to Dr. Sindhuja also for coordinating this entire masterclass.
And troubling you, sir, with pleasure.
No, so it's a pleasure for me to be a part of this. So thank you. And so I'm going to be talking about wait, let me just so all of us know that a lot of us are quite obsessed with doing ICSI in this day and age. And so I'm going to be talking about, the other aspect of IVF in comparison with ICSI and how we can overcome some of the barriers to achieving or to be able to do more IVF in our IVF labs. And then I'll talk a little bit about troubleshooting in general in IVF and ICSI. And I hope if you have any questions, then you can just shoot them at me and we'll try to make this session a very interactive one. So we know that the indications for ICSI have evolved over the past 3 decades, where initially ICSI was discovered and invented for the treatment of male factor. Then obviously the next patient group where the application became rampant were those couples where IVF did not work. Either they had failed fertilizations or poor fertilization. So there ICSI came in very handy. However, slowly, it started creeping into the territory of patients with no male factor, which had absolutely normal sperm, especially in patients with unexplained infertility. Then people started doing ICSI for advanced stage. Then they started doing ICSI for poor responders. Then in endometriosis, also gained entry. Then we looked at poor oocyte quality, pre-implantation genetic testing, frozen oocytes, basically anything and everything under the sun. So finally, now there are many labs across India and the world where ICSI has become is used routinely in all IVF cycles. And this trend where almost 70 to 80% of cycles where ICSI is not really indicated because they have normal sperms and probably can easily fertilize using conventional insemination techniques. They have been converted to ICSI. And this is a graph from the SART data where they showed that how rapidly in the past 2 decades ICSI usage has gone up. But what does the evidence say? Now there are so many papers which have been published, and this one was published in Lancet a couple of years back, where they have unequivocally demonstrated that ICSI does not improve live birth rates. And there are other, secondary problems associated with ICSI, like cancellation rates in comparison to conventional IVF. And, there are no benefits in terms of fertilization, but still we continue. We somehow cannot shift back to IVF. So what's holding us back? Probably desperation for a procedure which could eliminate failure of fertilization completely. We all know that whether it is IVF or ICSI, this is one area where we can never guarantee a patient that fertilization is going to occur, right? So we are still, that suspense is still on. And so people may think that, in this desperation, probably what you can do to probably try and minimize that chance of, total fertilization failure, and hence they resort to ICSI. Then a lot of people actually believe that injecting sperm into eggs will always lead to higher fertilization rates, and which will then translate into more embryos. So this belief has to be questioned, that just because if a physical barrier of the zona pellucida is overcome through injection, does it actually lead to higher fertilization rates? Because if that's the case, then sure, it makes a strong point for performing ICSI and all. Then also kind of provides a justification for the embryologist and the clinician that we did the best that is possible for our patients. This again has to be looked into, that whether it is really beneficial for the patients or probably for our own psyches. And also in some parts, it is considered that you can only achieve success with dedication and hard work, and perhaps ICSI is a very tedious process which requires a lot of dedication and hard work. And hence, if you want to do your best, then you must perform ICSI in all cases. So again, so the determining factor, if we look at scientific facts, before this, I just listed impressions, which may be playing while making this choice. But primarily, it is the risk of failed fertilization, total failed fertilization, or poor fertilization. Say if you were to be given a guarantee that a particular modality will result in a good fertilization, then I don't think anybody would opt for extra work and extra exposure entailed in ICSI. And the second determining factor is the eventually after the cycle, what is the number of embryos that were generated as a result of either IVF or ICSI, right? So we call that term now as utilizable embryos. So embryos which are either fit for embryo transfer or fit for freezing, because now we know that 80% of embryos are frozen and people resort to freeze-all cycles. So we have to change our thinking rather than purely obsessing over the risk of poor fertilization or failed fertilization as a deciding factor in making this choice between IVF and ICSI. We now have to start thinking about something which is more important than just occurrence of fertilization, and which is the end result of fertilization, which is embryo, right? And how many embryos do we end up with as a result of making this choice? So in order to demonstrate this, we just carried out this study in sibling oocytes, and it's right now, we have just submitted this paper, but it's fairly large. One of our fellows did this study prospectively over an entire year's period, where 125 cases were randomly split, were subject to split IVF and ICSI, which means half the eggs were subjected to IVF and half to ICSI. And the number of eggs allocated these are all large numbers we're talking about. So mean number of eggs in both the arms was absolutely the same, around 9.5 eggs. However, mean number of eggs utilized, or in other words, injected in the ICSI arm, which is the M2 eggs, the normal M2 eggs, were only 7. So you see, whereas for IVF, all the eggs were subjected to insemination. And the result that this had was that the mean number of fertilized 2PNs was statistically higher in the IVF arm, right? And also, what we saw was that the fertilization rate per egg allocated was higher for IVF. I hope you understand the difference between fertilization rates per egg and per injected egg, right? So these are rates which are, again, which take into account all the eggs, where the denominator is 9.39 and not just the eggs that were injected. So when you take all the eggs that were subjected to ICSI, the fertilization rate per egg was only 54%, whereas in IVF it was 65%. There were 4 TFFs in the IVF arm, and whereas there were none in the ICSI arm. So in 125 patients, 4 patients had a TFF. But obviously, since these were all split inseminations, these 4 cases got rescued because ICSI was performed in half the eggs. So right, so that's thumbs up for ICSI. However, so this is the first worry, right? The TFF that we have. But then let's move on to the next parameter, which is number of blastocysts, good quality blastocysts which were generated, which could be either be frozen or transferred. And see the number here, it was 291 versus 202, right? And also the mean number of blastocysts utilized was found to be statistically higher in the IVF arm as opposed to the ICSI arm. And similarly, we calculated the blastocyst utilization rate per 2PN, and which was, trending to be higher, right? Because trending to be higher with higher numbers. So this again shows that even though the blastocyst conversion rate was more or less similar, but because of higher oocyte utilization, we ended up with many more blastocysts in the IVF arm as opposed to ICSI. So actually we found out, so okay, right? So these are the figures that you must focus on. So when we quantified this, the data actually translated to a 34% reduction in the odds of obtaining a good quality blastocyst in the ICSI arm, where this was the mean number of blastocysts produced in IVF versus ICSI. And this is the best model to study the efficacy of both the procedures, because this was done in sibling oocytes, right? So we started off with the same number of eggs, but we ended up with a much higher number of blastocysts produced. So now you have to make this choice, right? So you have, on one hand, you have 4 fertilization failures out of 125. And on the other hand, you have around 85 extra blastocysts as a result of performing IVF. So now it's for you to think what you'd like to choose, right? So this was something that I wanted to highlight. And so, our expectation is always that ICSI will lead to higher fertilization. For obvious reasons, we tend to believe certain things. And uh, and if there's higher fertilization, then there'll be more embryos, right? So there'll be higher utilization rate. And we also think that there'll be no fertilization failure, right? So we agree that in ICSI there are fewer fertilization failures, even though for poor responders, the fertilization failure rate becomes very high with ICSI. But the reality is doesn't equate to our expectations. So the reality is that the fertilization rates per allocated eggs is always lower with ICSI, right? Because out of 10 eggs, you will always lose out 2 or 3 eggs before you even start. And then you are always struggling, you are catching up, because those mature eggs will then have, then 70% out of those mature eggs will fertilize, and so on and so forth. You'll end up with lower number of embryos. And like I said, a lower oocyte utilization rate, which means that fewer eggs were eventually utilized or were eligible to undergo fertilization, right? So fewer eggs were utilized than what were retrieved, will lead to a lower embryo utilization. And in this study, which was published in Lancet, so you must go back and read this paper from Vietnam, they found absolutely equivalent rates of TFF with both IVF and ICSI. We didn't see that here, because here we are looking at unexplained infertility hyperresponders with more than 20 eggs. So that's how, when we divide them, we get 9.5 in each arm. We are not looking at poor responders. These are all patients with very good number of eggs, right? So there we can see that even with ICSI, the TFF rate is 5%. So, but still, despite all of this, we know that there are real dilemmas every day in the IVF lab, where each of us, feels afraid that if I do ICSI, what will happen, whether it will fertilize or not. Nobody wants to face a TFF and then sit and explain that why you didn't do, and you could have easily done ICSI and it just saved us so much trouble. So, and those cases are poor responders, where there are very few eggs, 1 egg, 2 eggs, or anything in the vicinity of 6 eggs. Advanced stage, somehow we feel if it's a 42-year-old with few eggs, then better do ICSI. Then obviously one very important patient group is unexplained infertility with PCOS, with the long duration of infertility. Uh, and I am saying this because, now it's very important that this decision should not be taken by the clinician alone, right? This is a joint decision between the clinician and the embryologist. So I would urge all of you to, take advice from your embryologists and vice versa while making this decision, and not just, impose a random decision. It could be a elective decision. Sometimes it is understandable, but one must work as a team. Then endometriosis and This is one very interesting facet of patients where we've had multiple previous failed IVF or ICSI cycles. So it just generated some data. Okay, so also before I go on to the results, the only most important prerequisite for conventional IVF is a very good post-wash motile sperm concentration. So again, this decision of whether you want to do IVF or ICSI cannot be based on a previous semen analysis report, where you predetermine a patient uh, for with normozoospermia, because a lot of the times you will have normal sperm, but after processing the sperm semen sample, you will see a very poor post-wash motile sperm concentration. And in those cases, it is not prudent to perform IVF by just, increasing the number of sperms and trying to do IVF just because the initial pre-wash count was high. So this is a very, very important marker of fertilizing, ability of the sperm, which is the motility. So we in our lab, we take 8 to 10 million per ml as the cutoff for IVF. So say if we have a very good sample and we, after doing density gradient and swim up, we get a post-wash motile concentration of 3 million or 4 million, we then decide to do ICSI. We don't go ahead with IVF. So this is something again that you can, think about in your practice. This is a paper just to show that recently, in BMJ, they did this mega study where they looked at IVF versus ICSI in patients with normal sperm. And here they took a cutoff as 2 million motile sperms as the minimum cutoff for performing IVF. And even with such a low cutoff, they found that the cumulative live birth rate was absolutely same. And the total fertilization rate for ICSI was found to be 4.9%. And for ICSI, it was, for IVF, it was 3.8%. So, you have to keep reminding yourself that even though we are, perennially scared of fertilization failure, but it doesn't occur that often. It's very rare, right? You have to keep reminding yourself. And a lot of patient counseling should be done for the patient. You have to tell the patient that, okay, we are doing IVF for you. Why? Because there's a higher chance of blastocyst formation. We want you to end up with more embryos. Instead of one blastocyst, we want you to have 2 or 3, because that's what's going to, be game changing for you. But there is a 5% chance of fertilization failure. And you see the patient will say, okay, great, I'm ready for it. Let's do something which is more physiological. You should not just think, no, I'm very afraid. Clinician is under a lot of pressure. Let's do ICSI because I want to save my skin. I want to just get fertilization. I don't care what is the end result. I don't care whether there's any blastocyst in the end or not. Right? So this is something you need to think about. And okay, so can we pause right now, Dr. Sindhuja? And perhaps you can, because she has
Yes, sir. Yes,
organized some questions.
it's going so well. I'm having a great time listening to you.
Actually, halfway through, I have a million questions in my mind.
Me
but-
too. So I think, like Sir said, let's have the first poll.
So do I need to stop share?
No, sir. No, sir.
Oh, okay.
If you want to, okay, but it's not required.
No, it's all right. You go ahead with your stuff.
Okay, so we've launched the poll. I request you all to participate. The answers are anonymous, so this is just to make sure you're following. And after answering all this, maybe if you have any questions, you can post the questions. This is just for fun and just to wake you all up and make sure you're on track. So, sir, I think meanwhile, can I ask a couple of questions that people are answering?
Yeah, please.
Okay. So, sir, you said in your study, you split it was a sibling OCC study, I understand.
Yeah.
So, was there a criteria like you randomly selected the OCC and split them, or did you
Yeah.
kind of select the mature OCC, whichever looked mature for IVF? It was
No,
not.
no, absolutely random.
Okay. And so the minimum number of sperm quality, like you mentioned, so I think even in your study, you've used the 8 to 10 million
Yes.
post-wash.
Yes.
Okay. And was it a well culture or a droplet culture? So these are basic questions I just want.
We do large volume well inseminations.
Like in center well
You
dishes.
no, in the 4 well dishes, we actually use 5 well dishes,
Okay.
and we add large volume of media and we do group culture.
Okay.
So in each well, we have 6 to 8 OCCs.
Okay. Okay.
Yeah.
And I
Maximum
think,
number of eggs is 8 in each well.
okay.
In
And
continuation with your study, I just have one more doubt regarding the allocation criteria.
Yeah.
So you had the allocation criteria irrespective of whether it was PCOS, endometriosis, whether it was they're all unexplained, or you just excluded a few from that, or
Most of them were unexplained with PCO, and some of them were even from other patient groups. But the moment the number goes beyond 20, that's the time when all the uncertainty starts that what will happen. So let's play it safe and let's just split the number of eggs into IVF and ICSI.
how's the poll going, Sindhu?
good, ma'am. I think 30% have participated.
That's nice. We encourage all of you to please participate. None of your names flash here, so no worries.
So I think most of the students have a doubt of, we often say 50,000 to 1 lakh sperms per oocyte. So
Yeah.
is there a specific way to calculate it? Because that's when we just say, that many of them get confused. So do you have any specific calculation or any trick to calculate that?
No, you have to know you have to take into account the final volume of your uh, the volume of the media in which your OCCs are there, right? So say if we are doing group insemination, which is most people must be doing individual micro drop inseminations also. So we are doing, so if I have to calculate, then I have to see how many sperms I am adding. So uh, uh, we we do it in 500 microliters. So in one well, there is 500 microliters of media covered with oil. And so if I add, say, 1 lakh sperm, 100,000 sperms into zero point 0.5 ml media. So then the concentration becomes 200,000 sperm. And 200,000 sperm is going to fertilize 6 eggs. There are 6 OCCs which are there in that space. So per egg, then you can assume that about 30 to 40,000. You divide 200,000 by 6. So
Okay.
which is 35,000 sperm per egg. So you will make those decisions based on, say, if you have very poor morphology or mild teratozospermia, then you'll think that, okay, let me increase the number a little. If motility is a slight issue, then you think I'll increase. But yes, like you said, you'll stay in the vicinity of 50,000, close by 50,000 sperm per egg. We
Okay.
don't like to go beyond 50,000 sperm at all.
Okay.
Maximum is 50,000,
Okay.
right? So we think we probably 1 lakh sperm per egg would be a bit too much.
Too much. Okay.
And we actually operate in the vicinity of 20,000 to 40,000.
Okay. And this is for short incubation IVF, sir, or is this
That depends. If you that's a good question. See, actually the number of sperm that we are adding is not too much,
okay?
right? So you can do a long insemination.
So I think this is a very good point. That's why I wanted to know, because when they
Yeah,
add high numbers, they usually prefer just 4 hours.
yeah. With high numbers, even 2 hours is enough.
Okay,
But see, high numbers doesn't give you that advantage that we are trying to seek.
exactly.
Is that with IVF, we want time for the immature eggs to spontaneously mature and then become eligible for fertilization, which
Correct.
doesn't happen in ICSI. In ICSI, unfortunately, once you've denuded the eggs and if you find them to be immature, then they're out of the picture, right? But with IVF, if you leave them overnight, then you see a lot of spontaneous maturation and very high fertilization rates.
Okay. So I think I'm going to summarize all your excellent points now. So you mentioned well culture and you mentioned high volume culture, and then you mentioned 6 to 8 OCCs and around 20 to 30,000 sperms per OCC and overnight, like long incubation IVF.
Yeah. Yeah.
So if we all
Especially when
follow this,
you
then I think we'll get as good IVF success rates as these.
especially if you suspect the OCCs to be immature,
Okay.
then definitely you should keep them overnight. You should not take them out because then otherwise, what's the fun of taking them out after 2 hours?
Also, if you see any
Another,
clots and all those things, you prefer cutting the cumulus just to avoid any pH changes.
Um, Only if the cumulus is huge, is very big.
Okay.
But otherwise, we generally don't. We remove cumulus if there's a lot of blood attached to the cumulus, or if the cumulus is very unhealthy looking or post mature, then we may just want to trim it. If the cumulus looks post mature, then you should inseminate ASAP as soon as possible and
Okay.
not wait, because otherwise we wait for a minimum 3 hours before doing either IVF or ICSI.
so in other words, what is the criteria for short incubation?
For short incubation, you can perform short incubation for when you are doing conventional IVF for fewer eggs. But in cases where you're suspecting, oocyte issue in terms of maturity, then we think we have nothing against short incubation. We have done short incubation for the longest time. And it's good if you can, subject them for 4 hours of insemination, then you can go ahead. There's no harm in doing that. And long insemination for cases where you suspect eggs to be immature, then definitely long insemination will help.
Can you
Okay.
take this?
So it's past 8 minutes and 64% have participated. So I'm ending the poll and I'm going to display the results now. And I'm just going to read out the answers for the benefit of everyone. Yeah. Is it visible?
Yes.
Okay. So the first question was, out of the following, which type of oocyte should be injected during ICSI? So the answer is oocyte with one polar body. 68% have answered correctly. And then the key performance indicator for total fertilization failure rate in IVF is, I think sir mentioned it multiple times. So 48% have gotten it correctly. It's less than 5%. Oocyte utilization rate is defined as one of the following. 55% have answered correctly. Number of eggs utilized for fertilization by total number of eggs retrieved. And ideally, what number and stage of embryo should be transferred for a patient who has one child and does not want a multiple pregnancy under any circumstance the second time round? 86% have answered correctly. It's a single day 5 embryo. And then moving on to fertilization rate is defined as, so 70% have answered correctly that it's all of the above. So majority of others have also answered total number of 2PNs divided by total number of M2 is injected. So just
Yeah, and
understand that it's
even in the previous question,
Yeah.
In this question also, the 24% have said that number of embryos formed per total number of mature eggs injected. So yeah,
Yes.
so probably now it is clear that
Yeah.
you just don't have to take the mature eggs into account, but all the eggs,
And
that
also, no,
that
many
were
of the
allocated.
times I also wanted to ask, and your poll had that question, like all of us, our KPIs for ICSI fertilization rate is M2 fertilization. I think that is not the right way to.
No, but for fertilization rate, M2 is fine. Fertilization rate M2 is fine. So you can take out
Utilization rate.
fertilization rate per injected, per
Injected.
M2 and per egg.
Yeah.
Both are important. And in the Istanbul consensus, actually, they have mentioned fertilization rate only per M2,
Yes.
which is what is the what is the competence? I think it's 65% and benchmark is
65
80%.
and 80%.
Benchmark is 80%.
Yeah. So that is per M2. But you have to also calculate what is it per overall number of eggs.
So the last question was blastocyst utilization rate is usually expressed as, so equally divided answers in this one, but the right answer is number of blastocysts transferred and or frozen per number of 2PN embryos. So 23% have answered that. So whoever has not, so please make sure, you understand this point.
Yeah, that they are the number of embryos which have been used, not formed, because there may have been many more blastocysts which are formed, but they are not fit for transfer or not fit for freezing. So all the other choices have actually, they have mentioned it's number of blastocysts formed,
Yes.
which is not correct. We are only concerned with number of blastocysts which have been either frozen or transferred.
And I'll stop this.
We thought we'll give you a 2-minute voice rest during this polls, but then we couldn't do that.
We
Sorry
didn't
about
really do
Okay.
it.
So should we get on with the Dr. Sindhuja? Is this the poll is done?
Yes, sir.
Stop.
It's done, sir. Please.
So
Did you stop sharing, Sindhu? Because I just closed it.
Are you able to see it still?
No, now it's.
it's there on my screen.
Yeah, it was there on my screen also. I just closed
You
it.
can just close
Okay,
it.
yeah, okay, I can just close it. Great. Okay, so let's quickly move on. So this is some data about poor responders, where only 1 to 5 eggs were retrieved. So as you can see that, the total number of eggs utilized versus number of eggs injected was only 80% in patients with 1 to 5 eggs. So which means 20% of these eggs were not injected as a result of doing ICSI. And as a result, the fertilization rate per egg, was found to be much higher with IVF as compared to ICSI. And which then led to a statistically significant increase in the blastocyst utilization rate per egg also. But what I want you to focus is on the fact that we had a TFF rate of 5.3% with IVF in these cases with very few eggs, whereas ICSI led to 8.5% TFF. So this was, eye-opening for us. And according to the practice committees of ASRM and SART, they have clearly mentioned now that ICSI for low oocyte yield does not improve live birth outcomes. So all clinicians must take note of this, and especially when there are 1 or 2 or 3 eggs retrieved, they should not ask embryologists to perform ICSI because they're not doing themselves any favors. And here again, they found out that pregnancy outcomes of conventional IVF and ICSI in poor responders with only 1 egg were similar. Fertilization rate of mature oocytes in ICSI group was significantly lower, indicating that ICSI might cause oocyte damage, right? So choice of fertilization method should only be based on semen quality and not on any other factor, right? So this is very clear that if there is one egg, then just close your eyes and do IVF. Never do ICSI. Now let's come to the next patient group which is the other end of the spectrum, which is unexplained and PCO, where the number of eggs tend to be on the much higher side. So here again, you see that with ICSI now the utilization rate in the previous group, it was 80%. Here it is 75%, which means that 2.5 eggs out of every 10 eggs gets discarded on account of performing ICSI. And when we did split insemination, this 75% increased and became 88.5%. So somewhere in the middle of 100% and 75%. And so accordingly, the fertilization rate was around 65% in IVF, whereas in ICSI it was much lower, and in split insemination it was somewhere in the middle. Now here definitely the TFF rate was higher for IVF. It was 3.8%. In ICSI it was lower, and split insemination it reduced it to 0.7%. So which is great. So this was actually only out of 140 patients, there was only one patient where she had TFF with both in the IVF as well as the ICSI arm. So this could be actually a very good, method, which is split insemination to deal with patients with unexplained infertility with lot of eggs. And finally, eventually, we again see a significant difference in the blastocyst utilization rate per egg, right? Not just so both per egg as well as per embryo. So there are now papers also which have addressed this fact that sibling oocytes with both IVF and ICSI may prevent TFF, but they have seen that the embryo development in the IVF arm will always be better, right? So they are saying that split insemination design is actually a very good strategy to use. And knowing that you will obtain a higher quality blastulation rate in the IVF group as compared to the ICSI group, but you are performing ICSI only to compensate for those few fertilization failures, to rescue those cycles, right? Advanced maternal age, another group where, we again saw that same story repeated, that IVF gives a higher fertilization rate as compared to ICSI. And again, TFF rates in ICSI are higher because these eggs with increasing age tend to become more fragile, decrease in quality, and hence many of these eggs will not fertilize, they will degenerate. And so just by doing ICSI, you cannot increase the fertilization rate. Just remember this. As far as PGT cases is concerned, we keep getting these queries every day that earlier, ICSI was recommended for cases requiring PGT to eliminate the possibility of contamination from the sperm attached to the zona, where PCR was used for PGT. But now with next generation sequencing, this is less of a concern. And they found no difference in aneuploidy rates or mosaicism when different fertilization methods were compared. So this is again a committee opinion from ASRM and SART. So you can now safely perform IVF even for all patients requiring PGT testing, right? Endometriosis, where we think that oocyte quality may be hampered. And there was a paper which had once, shown that probably ICSI might be more beneficial in such patients, but no. Our data has equally shown that again IVF results in a more number of blastocysts for the same reasons that I have been telling you till now. And TFF rate is same in both arms. So to summarize, what few snapshots of our data have shown that use of IVF is absolutely justified in patients with less eggs. We have seen a higher risk of TFF with ICSI and lower blastocyst yield per egg. Then in unexplained infertility, split insemination seems to improve the blastocyst yield per egg and minimizes the risk of TFF. And as far as advanced maternal age and endometriosis are concerned, we've seen an equal risk of TFF in both groups. And in endometriosis, we've actually seen again IVF outperform ICSI, right? Again, few patients where it's a very easy decision to perform IVF is patients who've had proven fertilization with IVF in previous cycles. So there you don't have to think. Then patients who've had previous natural conceptions. There again, it's mostly safe to do IVF. And patients who've had, previous secondary pregnancies or missed abortions or ectopic pregnancies. Again, IVF does very well here. And obviously, all of this has to be coupled with a lot of counseling to the patient that what is the reason why you are choosing IVF? And it is highly uncertain. Nobody can guarantee fertilization at the end of a cycle. But you are choosing IVF because you believe that you will be able to make more blastocysts for them. To summarize, again, we've spoken about this. Just one more patient group, patients with mild teratozoospermia. We have seen that IVF works very well. And recently there was a paper, and there's going to be a, for Academy of Clinical Embryologists, the Journal Club series, we are going to discuss this very good paper, which has just been published in Human Reproduction, where they have specifically looked at teratozoospermia and whether it makes a difference in fertilization rates comparing IVF. So all other cases, especially first cycle, young patients with short duration of infertility, they all do really well with IVF. Tubal factors with normozoospermia, previous failed ICSI cycles. A patient has been going through two, three, cycles every time going through ICSI, non-indicated ICSI, where they have great sperm. And the same complaint, poor embryos, poor embryos, poor embryos, no blastocysts. And then we say, okay, then why the hell are we doing ICSI? Let's just do a conventional insemination and see what can go wrong. And then we see diametrically opposite, results with conventional IVF. And the only prerequisite for IVF is a good post-wash, swim up the motile sperm count. That is the only prerequisite. So it is so now I have underlined this fact now multiple times that this is a crucial choice. And because it determines the number of utilizable embryos at the end of the cycle. Okay. And rather, ICSI may prove to be very detrimental for some patients, such as those with very few eggs, with immature looking OCCs, for advanced stage, for repeated failed cycles where ICSI was performed with no indication again and again and again, suspected poor quality. And when we do end up doing ICSI for such patients and we find all eggs are immature or all, then we are kicking ourselves that why did we do it? Why we didn't leave the eggs with, good motile sperms overnight and see if they're fertilized. So that's about it. Dr. Vasundara wanted me to include some stuff on troubleshooting. We still have 5 minutes left, so we'll just finish this. So if we encounter a drop in ICSI fertilization rates now, so how do we troubleshoot? Because I think everybody is obsessed about this, right? That when we start seeing a drop, and when I say a drop in ICSI fertilization rates, please understand that this is not individual cases. right? A drop means at the end of the month after doing, or after doing 50 cases or 100 cases, you calculate the overall fertilization rate and that goes down significantly. That is a drop. Please understand, it is not one patient, if you got 20% fertilization and the other patient you got 80% fertilization, then you start troubleshooting that why did patient A have 20% fertilization, right? So here, first thing that you look at is that you examine the patient population and you correct for confounders like age, sperm factor, like very severe, male factor, then very poor responders via proper statistical methods, right? It is not impression based, that because you think that the cases were poor, because every clinician at the end of the day will think that cases were great and embryologists will say cases were very poor. Next, once you have established that no, there has been a proper dip where the fertilization rate in your control charts has gone below 2 standard deviations from the mean, and it is persisting there for 2 months, minimum of 2 months, you know that there is some major problem in the laboratory. So then you will also look at the operator performance, where you see, has someone new joined in, a new joinee, a new embryologist possible? If not, then don't worry, because overnight an embryologist will not forget his skills, his or her skills or techniques, right? So only if there's a huge number of embryologists, there's a lot of different people performing ICSIs, then this point is important. And then you will start looking at the laboratory, where you see the temperature of the heated stages, because sometimes unknowingly the temperature spikes up without your knowing, and then as a result eggs are getting fried. And then you look at the incubator culture conditions, where you check temperature, you check the culture media, the pH, osmolarity, air quality. And then finally you again make sure that the gas, because gas is one variable which keeps changing every month, that the composition of the gas mixture should be verified. And finally, and in my experience, the most vital is toxicity of the plastic dishes or the utensils or the consumables being used. Because again, uh, we know that this is a very, very crucial variable which can affect fertilization rate. So I'll give you a specific example where uh, in a laboratory, the ICSI fertilization rate per M2 eggs actually dropped to 50%, right? And they had the same operators, no new staff was introduced. They verified the temperature, all the temperatures in the heated stages, and the incubators was fine. Because the IVF fertilization rates were same as before. There was no drop in the IVF fertilization rate, but the ICSI fertilization rate went down drastically. And they found that no new lots of plasticware were introduced, like dishes and needles. So, you tend to have large lots of dishes and needles. But they finally found that the drop in the ICSI fertilization rate coincided with the new handling media. And the moment that lot was replaced, the fertilization rates recovered in the following weeks. So it was a culture media problem, right? Especially the handling media. Then another very important troubleshooting issue with respect to ICSI is damage rate. Suddenly creeps up in a laboratory. You suddenly start seeing over a period of time, over a month or 15 days or 2 months, that a lot of eggs are getting damaged. Almost 2 out of every 10 eggs injected. So there again, this has to be considered to be independent of operator skill. This is not the operator, right? Unless it is some newbie. with very poor technique, who's learning, who's just started. But otherwise, there will not be a increase in the egg damage rate. What will it be? It will be the equipment. It will be the tools of ICSI that if you change the needle and suddenly you see a spike in the damage rate, it will be vibration during the process of injection. If suddenly, some construction is going on or something has happened in your building or the anti-vibration table has stopped working, then improper denudation. Again, these are all things in line with new people coming in. Timing of ICSI, temperature of warm state. So these are the places where you have to look at. Then culture conditions again during denudation, during ICSI, what is the media being used, what is the temperature? These are the things which will lead to damage and not the operator. Stimulation protocols, I don't know if that can have this a consequence like this. I really don't know, and I don't think that it can. Um, so yeah, great. 8:30. We
Oh,
finish.
thank you so much. Sindhu, while you post the next set of polls, I will just be, talking to Gaurav. Thank you so much. Actually, you moved our perspective of, switching over to IVF because now the norm all over India, I think most of the world also is ICSI for all. I don't know, irrespective of everything. Now you told us even one egg, very important point that one egg by ICSI you can damage it. Probably the sperm parameters are very good. Why
Yeah.
not do an IVF and salvage that,
Yeah.
egg if all other parameters. So I think it requires that courage and change of mindset which has been there over the years, and also the attitude in the current generation of embryologists who feel that ICSI is a benchmark of their competence and skill. If they do a ICSI, they feel very proud, and that's they want the chance to do ICSI. They want to handle the micromanipulator, do the ICSI. But I think IVF training is more required, and we have to just get back to nature. I really thank you wholeheartedly. You have done so much justice to the topic, and you have inspired a whole lot of people to do more IVF and stick on to ICSI only for indicated cases, that being male factor, total fertilization failure in the previous cycles. Anything else you would want to do ICSI? Even PGT, you are saying that we can do IVF, where I saw
Yeah.
that paper. So we are all more worried about what could happen. What about frozen oocytes? Uh,
Frozen USA is right now, the recommendation is to do ICSI.
yeah. So, in this vein, there are some questions in the chat box. But with regards to going for IVF, just as a mind game, do you recommend doing DFI testing before, though the sample can be normal, still you suspect there's some unexplained factor and you land up in some trouble later on? Do you do that?
We don't do DFI testing.
Okay.
We like to keep the period of abstinence very short for our
Okay.
patients.
Okay.
So we tell them that maximum 2 days abstinence before providing a sample on the day of OCR. And in case if they come with DFI reports of slightly higher DFIs, then we tell them to undergo serial ejaculations leading up to the OCR, and that only brings down the DFI drastically.
So that doesn't, change your decision for IVF, even if they
No,
come
no.
with a report
We
of
don't
very
perform
DFI.
DFI testing
No,
only.
no, even I understand, but then the patient who's come with a DFI elevated report to you and you still say frequent ejaculations, that really requires that much of thought
Yeah.
and that much of
Because see,
convincing capacity.
DFI, there is no association of DFI with fertilization. If at all there is any association which has been proven, that is DFI has a direct link with pregnancy losses. And there's a big question mark over association of DFI in RIF with implantation failure, right? But as far as fertilization is concerned and embryo development, I don't think DFI has any role.
Okay. So since yours is a teaching institution, you're able to convince your patients saying that, vaccination will be better with a natural selection and things like that. Centers who are operating like, single centers or, where patients come, they, want to do ICSI. They think that ICSI is superior with the amount of social media awareness which they have. it is kind of very difficult for us to, kind of convince them for an IVF, though we tell them the rates and everything. So what are the challenges and how should we actually counsel the patients?
No, so Dr. Vasundara, now you'd be surprised to hear, uh, even amongst my colleagues in Delhi, we talk in the major hospitals. How many people are now going back to IVF? Because they feel that, sometimes with ICSI there are a lot of variations. And now, slowly with awareness, uh, if you start doing IVF in safe cases. Who's asking you to do IVF in all? You start doing IVF in safe cases, you start doing half and half, and then you see your results. And then that is evidence for you. If you have evidence that by doing IVF, you are making more embryos, then you will be able to convince every patient.
That's a wonderful take-home point. Now you're talking about long incubation, right? It just came to my mind, my dear, not the right thinking. Like, when you feel that a cohort is having less mature, COCs, then you want to incubate it for long. So
Yeah.
sometimes when we do IVM cycles,
Hmm.
do you think we can do, conventional insemination or you have to just do ICSI?
See, IVM cycles are cycles where they've received minimum stimulation, and they are, immature by virtue of minimal stimulation. Right. So they're not supposed to be mature because you're taking out eggs at a smaller size from smaller size follicles, and you have hardly given them any gonadotropins. Here we are talking about eggs which have received the full-blown stimulation of gonadotropin for 10, 12 days. And then the only problem is they are slightly lagging in the cytoplasmic maturation. Right. So giving them that extra 2, 3 hours to make up that lag of cytoplasmic maturation and then undergo nuclear maturation. So that is different than IVM, where you need a minimum 24 or 48 hours for those eggs to mature.
Correct.
Yeah.
What is the poll status, Sindhu?
There are 4 questions now. Oh, okay, great. So a lot of people have answered.
Oh, I'm so sorry. I didn't realize I was on mute. The 57% have participated. Meanwhile, the chat box questions. I think the first one you already answered. Why we prefer higher insemination concentration during short co-incubation. So I think sir mentioned that he prefers a lower concentration and a longer incubation. Maybe if you're asking this question, then to increase fertilization rates to give higher chances.
Higher concentration doesn't help really. No?
Okay.
Then you should be worried about the excessive cell death, sperm death, and release of ROS.
ROS.
And especially if you are, see, if you're doing micro droplet insemination, then definitely you must only do a short insemination. Then long insemination is not a good idea. For that, those OCCs to be in that concentrated drop of sperm overnight is not good news. But if you're doing large volume insemination, then there's enough dilution which takes care of the ROS buildup.
What are the points when you do, discharge or change of replenish the media in conventional IVF cycles?
Just make sure that the exposure is minimum so that there's the fluctuation in temperature and pH is minimal. So
No,
you
on
have to
day
keep
three,
it.
do you change the
Oh,
dish on
yes,
day three?
yes. We change media from, so we use sequential media, but this irrespective of whether you use single step or sequential media. I believe media has to be changed on day one morning because that's the time for fertilization check. And then 48 hours later, on day three, when we assess the embryos, we don't look at embryos on day two. So we look at embryos on day three. And that's when we change media to blastocyst media. And then we go up till day 5, and again we change media on day 5. Because we culture all our embryos till day 6. So every embryo gets a chance to grow till blastocyst for 6 days. Nothing is discarded based on embryo quality on day 3 or day 5. So we do these changes on day 1, day 3, and day 5.
So whether it is a single step or sequential, these changes happen at day 1, day 3, and day 6, day 5.
They should. Sequential, you have to, because
Yeah,
you have to change the
yeah.
media, right?
Yeah.
You have to go from fertilization media to
Cleavage to-
cleavage media to blastocyst media. But I would assume that it is paramount even in a single step media.
So in IVF, you feel that sequential media is better?
No, for ICSI also. For
Right.
ICSI also.
So the next question is when to decide for rescue ICSI?
When to decide for rescue ICSI?
Is the question in the chat box. Yes.
Ideally, you would only get to know about fertilization failure on day 1 morning, but it's generally too late by then. And but you must remember one thing, that if you want to perform rescue ICSI, if at all, then it has to be with new sperm. You cannot use the previous day's sperm which is sitting with you. So you have to ask the patient to give a new sample, because that previous day's sample will not work. And secondly, then if you do end up making embryos, then they cannot be transferred in the same cycle because of the asynchrony of one day. Then you have to go through a FET. But one thing that people in China did, where the government, they made a rule that you cannot do more than 30% ICSI. They just made a rule that no matter what, you cannot do more ICSI. You have to do IVF, whether you like it or not. They don't care whether you have a TFF. Uh, but they said, okay, let's put a complete stop to indiscriminate ICSI. So then there they started denuding the eggs 6 hours post IVF in the evening at 8 o'clock. And there, if they saw two polar bodies, then they left the eggs. But if they saw still a one polar body, then they did a rescue ICSI there and then. And there it seemed to work better, because by next morning, actually, a lot of aging has occurred for those eggs to then work.
Next question is why we opt for IVF in cases of previous ectopic pregnancy or miscarriages? I think you mentioned that because they have proven pregnancy previously, so IVF is a better
So for
option.
miscarriage, that fertilization occurred and there was an embryo which then implanted. And the
Yes.
fact that it didn't carry forward, but at least that fertilization is not the problem area.
Yes. So the last question on the chat box is what time is good for denudation and ICSI after oocyte retrieval, and how long should we wait for ICSI after denudation?
I'll tell you what we do. We give a minimum of 2.5 to 3 hours post OCR for cytoplasmic maturation to take place. And after that, we denude the eggs, and we don't keep any time, we denude and we inject. Because we want to make sure that the injection has to be over within 40 hours post HCG trigger. So you have to calculate that you are taking out the eggs at how many hours post HCG. So some people like to take out eggs at 35 hours, which gives you 5 hours then in hand. But if you're taking out eggs at say 36 hours, and some people even go further till 36.5 hours, then you have only 3.5 hours in your hand, because you don't want to exceed 40 hours post HCG. So then 3 hours will go in, if you're waiting for 3 hours or even 2.5 hours, and then you have to perform ICSI. So it's not advisable to wait after denuding the eggs. Leaving them naked without the cumulus cover in culture media is not helping.
What is the protocol in your lab when you have more of M1s and GVs? I know the protocol is the stimulation. Suppose we get 20 oocytes and sometimes 10 are M2s and remaining are all M1s and GVs. So what do you do with those?
It's really not much that you can do, especially with GVs. You can't. If majority are M1s, then we wait. But how much can you wait? But you wait, and you wait till the end of the day to see if something has matured. That's what we do. Sometimes in desperation, you will end up injecting a M1 egg, especially if there are only 1 or 2 eggs that have been retrieved. But that also seldom helps.
Can we take the poll answers?
Yes, ma'am. I'll end the poll now.
Yeah.
I'm sharing the results. Okay, I think everyone can see the answers also. So the first question was, ICSI is indicated for which of the following patients? 70% have answered patients with unexplained infertility and bilateral PCOD, which is the correct answer. And I think one of the main take-home points was, even if there are 2 eggs retrieved, we can still go ahead with IVF. So the 24% who answered that, please make note of that. And the next question is, which of the following is a limitation of ICSI? All of the above is the answer, and 88% have answered correctly. ICSI is not indicated for which of the following patients? 48% have answered actually that the first cycle young patients with normozoospermia. So the correct answer is actually poor responders with few eggs retrieved. So I think this was a trick question. And the competence levels and benchmark level for ICSI fertilization are, majority have gotten it correctly. It's 65% competence and 80% benchmark. So, sir, I think you've succeeded in conveying most of your points. And
Yeah,
whatever,
I'm happy that at least 70% of people got some take home.
definitely, sir.
Thank
Thank you
you
so
so
much.
much. Yeah, thank you so much, all delegates, for taking part so actively, and our sincere thanks and huge respects to Dr. Gaurav for giving us our precious 1 hour and 45 minutes, 1 hour and 15 minutes over. Thank you so much for this, and I think many of us will definitely take home, consider doing IVF again, back to nature. We should, practice this in our day-to-day ART lab, and most of us, as he rightly said, it should not be a pressure from the clinicians to the embryologists that 1 egg, 2 egg and things like that. It has to be discussed mutually and, made a collective decision even before we, actually go in for the case. And at any point, if we all have any trouble in IVF, I think we can contact Dr. Gaurav anytime to troubleshoot in our labs. I hope I can take that privilege and, ask that in this
Yeah,
form.
yeah. Of course, I'm always available, and it was a pleasure, Dr. Vasundara and Dr. Sindhuja, to be a part of this masterclass series. And again, many congratulations to you guys.
Thank you so much. We will
Thank you,
catch up
sir. Thank
soon.
you so much for your time. Excellent take-home points. It was really nice. I thoroughly enjoyed. I'm sure everyone else did too.
We will share the feedbacks also with you. And I request all the delegates to kindly share your feedbacks as usual. And we'll see you soon in our next masterclass. Thank you so much.
Right. Thank you.
Thank you, sir.
Thank you.
Good
Good
night.
night. Good night.